Hello everyone, my name is Drew Charles, and today we are going to discuss your specialty-specific and trustable professional activities in internal medicine. I've created this lecture series on applied bacteriology to discuss common infectious disease presentations and how to approach, work up, and treat them appropriately. The common infectious diseases that we will be discussing throughout this lecture series include urinary tract infections, skin and soft tissue infections, upper respiratory tract infections, pneumonia, and Clostridioides difficile infection. Today we will be discussing urinary tract infections. The learning objectives for this talk include distinguishing urinary tract infections from asymptomatic bacteriuria, determining appropriate antibiotic therapy and duration of treatment for elderly patients with urinary tract infections, and understanding the association between indwelling urinary catheters with UTIs and asymptomatic bacteriuria. When approaching a patient with suspected urinary tract infection, what are the ideas that should be flowing through your mind? First is going to be the patient presentation. What signs and symptoms should you be looking for when taking the history? Knowing that the common manifestations of urinary tract infections include dysuria, suprapubic pain or pressure, or urinary frequency or urgency. Once gathering that information, next, is there further workup warranted with this patient, or can I just treat this patient empirically? If I do plan on continuing a further workup, what tests do I order? And when I order that urinalysis, what am I looking for in the urinalysis? Knowing that you're looking for not just the presence of bacteria, but also inflammation markers and how to interpret that. And when going through this approach to a patient, try to avoid anchoring bias, meaning keep your differential broad. Don't just hunker down on urinary tract infection. Keep a broad differential, including sexually transmitted infections, interstitial cystitis, if there's been any urothelial trauma, prostatitis. And when choosing treatment, know what are the common bugs that cause a urinary tract infection and the different antibiotics that are recommended first line that target those suspected bugs. Also determining, is this patient presenting as a complicated urinary tract infection versus uncomplicated, because then that's going to help choose the duration of treatment. And then knowing your patient at hand, does this patient warrant a test of cure after I've completed the treatment of a urinary tract infection? The best way to go through the thought process is to apply it to a case. So here's case one. An 86-year-old male with peripheral vascular disease presented to the emergency department with a painful and cold left foot. He has a chronic indwelling urinary catheter for urinary retention. He is seen by vascular surgery and they take him to the operating room for critical limb ischemia. He received perioperative cefazolin. Post-op, no antibiotics were given, but then the team noticed the following urinalysis obtained from the urinary catheter as part of the pre-op clearance. Urinalysis is positive for blood, leukocyte esterase, white blood cells, and bacteria. The culture results are pending. How should we respond to this urinalysis? I hope you took some time to think about what to do next, and I hope you chose to do nothing. It can be challenging when you're dealing with a patient with a catheter, but there were no signs or symptoms in this patient. No evidence of suprapubic pain or urgency. Thus, there was no indication to obtain a urinalysis to begin with. Even though the urinalysis had leukocyte esterase, WBCs, and bacteria, it is more likely this is asymptomatic pyuria due to colonizations, which does not warrant treatment. When dealing with colonization, the bacteria in itself can still produce leukocyte esterase, cause increased number of white blood cells in the urine, and nitrites. This does not mean that there is an infection. It can be expected that a patient with colonization can have these urinalysis results. And to take this one step further, what is the definition of a catheter-associated urinary tract infection according to the IDSA guidelines? That would be the presence of symptoms or signs compatible with a urinary tract infection with no other identifiable source of infection, along with 10 to the third colony forming units per mil of one single bacterial species in a single catheter urine specimen. Now say we have the same case, but the patient does not have an indwelling catheter. How does that change your thought process? Going back to the case, the patient did not have any urinary symptoms, so you would still do nothing. This is what we call asymptomatic bacteriuria. Studies show that older men living in the community have 4 to 19% asymptomatic bacteriuria. However, given the blood in the urine of this patient, further workup is warranted for his hematuria. Next question to consider: does this patient warrant a recheck of his urinalysis? And the answer would be no. Routine screening is not recommended for asymptomatic bacteriuria. However, there are cases when this is required, such as in pregnancy. Routine screening and treatment for asymptomatic bacteria is warranted in pregnancy, along with a test of cure to ensure eradication of the organism. Let's move away from the asymptomatic bacteria and talk about a true infection. So you have a patient that presents with the classic burning with urination and frequency. What are the common pathogens that you are thinking of? So you think of the Enterobacteriaceae family, most commonly being your E. coli, but also other organisms like Klebsiella and Proteus within that family. And then also consider the Staphylococcus saprophyticus, which is the honeymoon bacteria, as you all may remember from studying for boards. And then some question I want to pose to you is, what if there was Staph aureus growing from the urine? What do you think of then? And what you should be thinking about is hematogenous spread, that bacteria is present in the blood and that's how it got into the bladder, not vice versa. Determining complicated versus uncomplicated urinary tract infection is important because it determines antibiotic choice and duration. So on the left side we have what makes a urinary tract infection complicated. So anyone with diabetes, anyone who's immunocompromised, if there's a structural abnormality like duplicate ureters, foreign body, and that includes any type of renal stones, resistant organisms, in all males. So if you classified someone as having a complicated urinary tract infection, the antibiotics you'd like to choose is the trimethoprim sulfamethoxazole for 7 days or fluoroquinolone for 7 days. And be sure to check out your local resistance so you can tailor which antibiotic is best for your patient. All others fall into the uncomplicated category, and here the duration of treatment is shorter. You can use your trimethoprim sulfamethoxazole for 3 days, nitrofurantoin for 5 days, or fosfomycin for 1 day. I've provided a take-home point slide to make sure that you really grasp the key points that I was trying to get across in this lecture. So to summarize, remember that not all bacteriuria is an infection, and asymptomatic bacteria should not be treated except in certain circumstances. Know the common pathogens, including E. coli and Klebsiella pneumonia. Be able to differentiate between complicated and uncomplicated infections because this affects duration and the type of therapy. And as a reminder, I encourage you all to further review the IDSA guidelines for a more detailed look at the material covered in this lecture. I've provided the links at the bottom of the review slide. Thank you.